So now we're going to move on to Dr. John Inadomi, who is the head of the Division of Gastroenterology at the University of Washington. He's a major leader in this field, is the principal investigator of multiple grants in GI cancer, and then very importantly is the incoming president of the AGA, one of the major GI groups in the country. So he is joining us by Zoom. I think we see him here. So Dr. Inadomi, welcome.
Thank you so much. As a member of the AGA, incoming president, I thought it'd be really useful to explain the guideline process and the grade process in particular. So in about 15 minutes, I'm going to go through our process. Now, in about 2011, the Institute of Medicine published the criteria for the guidelines, and they followed these steps. They wanted to establish transparency. They wanted to manage conflict of interest between the guideline writers and industry and other such things. I wanted to standardize the guideline group composition, ensure that the evidence is based on systematic reviews. I wanted to have a systematic way of rating the strength of recommendations, a way to articulate the clinical recommendations, make sure there's an external review of these guidelines, and then every guideline has an expiration date, so how to update the guidelines. So prior to 2012, the AGA put out medical decision. These were problematic because the evidence was not systematically evaluated, and the risk of bias was high. There was a lot of transparency lacking. You couldn't tell whether the guideline authors had any kind of conflict or ties with industry. And probably the worst thing is that when there wasn't high quality evidence, we're unable to provide recommendations because we're a process for these medical decisions. So I want to introduce the grade methodology. It was initially an informal working group of clinicians and methodologists. Originally in 2000 and then fully established in 2003, have a very broad representation. And grade stands for grading of recommendations, assessment, and evaluation for rating the quality of evidence and strength of recommendations. And currently, grade is recommended by over 100 organizations, including the major GI organizations. And there's four major parts of a grade process when they develop a guideline. First is to identify the scope of the guideline. What is the breadth and depth of the guideline? And we can probably talk about this, the PICOs. The PICOs are that, what patients, what interventions we're looking at, what's the comparator, what are the outcomes. Oftentimes when people or reviewers or readers of the guideline have an issue with the guideline, it's often because of the PICOs. What it actually is the questions that the guideline is trying to answer. And that is in many ways almost important as the guideline process itself. Next is we're supposed to gather the evidence, and it's not going to be based on just on a few randomized controlled trials, but rather hopefully performing a systematic review of the evidence across trials, across multiple outcomes. Next is, I think most of them know, you assess the quality of evidence. And the idea here is you look at study design and the risk of bias according to the study design. And the difference between grading and our prior process is that it's looking at the quality across studies as opposed to just by each study. And then when we assign the strength of a recommendation, it's not just based on quality of evidence, which is the old way, but also three other categories. And the second is the patient preferences. The third is a balance between the harms and benefits of intervention. And finally, resource utilization, or I've heard several talks about cost effectiveness today. And that is certainly something that is taken into account in the grade methodology. Also important in the grade methodology is the fact that we separate the technical review from the guideline. And the reason for that is the technical review requires experts who know the hot topics, the controversies, know the literature, know the emergency evidence that may not even be published. However, these experts are likely to have the greatest conflict of interest. I mean, they're the experts, so oftentimes have industry ties, and for obvious reasons. They may even have funding agencies, including NIH or VA funding or DoD funding. All of these things can potentially lead to a conflict of interest when assessing the literature and establishing these recommendations. So the technical review is done separately by the experts. And separate from that, you have the guideline panel, and requires that these members of the guideline panel represent all stakeholders. So for our guidelines, one gastroenterologist, one primary care provider, providers, pathologists, radiologists, surgeons, pharmacy, and patients themselves. As we heard from Aki, that's a really important part of this, is to make sure that patients' voice are being heard. And to the extent possible, we really try to make sure that the guideline authors are free from conflict of interest. And that is why we have a firewall between those who have the technical review, or again, the experts, but mostly may have a lot of conflict of interest, and the guideline authors. And so when looking at the evidence, there's a couple of things we want to do. One is to look at the risk of bias. Even in a randomized controlled trial, there are potentially methodological limitations. Blinding, I think everybody knows, it's ensuring that both the investigator and the patient or the subject don't know which arm they're in. Allocation concealment is a little bit slightly like this, except that it's whoever's enrolling patients into the study doesn't know what's the next number of. There's been prior studies showing that if that person enrolling patients actually knows whether the patient's going to be randomized to the placebo or the intervention, they may actually change who they actually decide to enroll in the study. Intention to treat as opposed to per protocol, and of course, making sure they have adequate follow-up. If you have any problems with any of these particular aspects, the methodology is not as great, even if it's a randomized controlled trial. Also, we're looking at outcomes across studies, not within a study. So if you see different studies, and here just an illustration, inconsistencies in the results where one study is protective and one study is harmful, that's a problematic issue. And if you look at across studies again, this would reduce our certainty of the evidence. Indirectness of evidence is also really important. The indirect comparisons, for example, in gastric cancer, was an intervention done in Korea or Japan or China? And are we trying to convert those kinds of results into a US population? That's indirectness, whether or not there's differences in patients, so the intervention, the comparator, or the outcomes. Also, if there's imprecision, not just is there inconsistency, but imprecision in terms of the confidence intervals, the reliability of these particular the data, and whether or not the confidence intervals are tight or not. And finally, whether there's publication bias. We all know that if it's a negative study, it's much harder to publish than if it's a positive study. And so oftentimes publication bias will introduce more positive studies showing that, let's say, an intervention such as screening or surveillance for gastric cancer would be more effective, ignoring the fact that some studies that didn't show an effect perhaps were not able to be published, right? But beyond this, we want to understand that there's methodological limitations due to a study. That's increasing the risk of bias or allocation concealment, their blinding, incomplete reporting, or losses to follow-up. And that affects the evidence, the quality within a study. But beyond that, between studies, there may be consistency of results, indirectness, imprecision, and publication of bias. So what the grade tries to do is not only take account for the evidence within a study, but between studies, make sure that's all incorporated. So in terms of my final slide about quality, quality assessment is assigned by this. Certainly in terms of the study design, the randomized controlled trials start with an assumption that's higher quality evidence, whereas the observational studies, such as a case control study or prospective or retrospective cohort study, they start as a low quality evidence. However, even in RCT, that quality can be lowered. Problems with the risk of bias, such as problems with blinding or concealed allocation or randomization or follow-up or intention to treat. Also, between studies, if there's problems or decreases in consistency or directness or precision or publication biases, they also can lower the quality of evidence, even of a randomized clinical trial. Conversely, observational studies, such as case control studies, that quality can be increased if you have a large effect. Let's say if you have reduction in a particular cancer mortality is by 50%, or a very large effect, let's say a relative risk of 0.2 or an 80% reduction in cancer risk, well then certainly the quality of that particular outcome may be increased, right? If you can see a dose response gradient, so more endoscopies, you have a higher reduction or a greater reduction in cancer rates, then that would be evidence of increasing quality. Or if all the plausible confounders you can think of in a study all lead to a potential effect, you have a higher effect no matter what you see, you assume that the worst is you still get a good effect, that you can actually have that the quality assessment be increased. I talked about this, the old system, we assessed quality per study, and now we look at outcomes across studies, and that's the grade process. And so when you move from the quality to the recommendations, it's not just the quality of evidence, that's only one of the areas. We also look at the balance between the benefits, the harms, and the burdens to the patient. We also look at patients' values and preferences that may be somewhat related to the harms and benefits, but they're separate. And then resource use or cost effectiveness. So all four of those components are necessary to arrive at a conclusion, right? And that conclusion is based on a recommendation. Those recommendations are either strong or conditional. When a recommendation is strong, meaning that, let's say, that quality of evidence is high, we feel that the benefit is much greater than the harms, patient values, the patients would want it, and the resource use, meaning that's cost effective, then we would say something like the AGA recommends using or doesn't recommend using. And that's a strong recommendation, right? Versus conditional, which means that perhaps the quality of evidence is not as great, or there's more equipoise between the harms and benefits. Then we would use the words suggest, either suggest using or suggest not using, all right? So there's a terminology as well as a definition of a strong versus weak or conditional recommendation. The implications of a strong recommendation are from the population. It means that the most patients in this situation would want the recommended course of action. Only a small proportion would not. From a healthcare worker, you would expect that most people should receive that recommended course of action. In terms of a policymaker, the recommendation can be adapted as policy, or let's say a quality metric, something that potentially could be used as, let's say, differential reimbursement or something along the lines of value-based purchasing. Whereas a conditional recommendation or more weak recommendation, from a population standpoint, the majority of people would want to recommend it, but many may not, right? From a healthcare standpoint, this is where we have to provide shared decision-making. Perhaps this is where a decision aid would be most helpful, to help people understand, to make a decision that's consistent with their own values or their processes. And from a policymaker standpoint, this is certainly, you couldn't use it as a quality measure. You should be using it as a value-based kind of reimbursement. And so there's a substantial amount of controversy with regards to that particular recommendation. So my last slide is this, and that's basically that in terms of the grade process, it's using an internationally recognized rigorous framework to develop impactful guidelines. The main purpose is to mitigate conflict of interest, and the expansion upon prior types of processes where that instead of just basing a recommendation on the quality of evidence, it also incorporates patient preferences. There's a balance between benefits and harms of the intervention, and also an assessment of the resource utilization or cost effectiveness. Finally, it fulfills the requirements for development of quality measures. And as I alluded to, this is potentially where we could actually use this, a strong recommendation, and those kinds of methods could be used for differential reimbursement and specifically value-based reimbursement. And so again, not so much on gastric cancer, but you can see the processes that are involved in making a guideline, especially with this grade process, not just the AGA, but across the board. And I hope that the the Q&A process, and perhaps what we can talk about the rest of the conference is really what are those holes and how can we fill them to be able to create a guideline that would advocate best for our patients and reduce mortality and the burden of quality of life from gastric cancer. So thank you.